Thank you for joining us for the Native Center for Alcohol Research and Education webinar series. My name is Cole Alec, and I'm the Tribal Liaison here at Partnerships for Native Health, which is a research program at the Institute for Research and Education to Advance Community Health, also known as IREACH. In this webinar, our presenters today will give a presentation on the relationship between prenatal alcohol, SIDS, and stillbirth, the Safe Passage Study. Next slide, please. Before we begin the webinar, I'll give a brief overview of Partnerships for Native Health at IREACH and the Native Center for Alcohol Research and Education. Next slide. IREACH at Washington State University challenges the status quo and advances community health through partnerships and collaboration. We conduct research with rural, Native, and Latinx populations, health networks, and populations with substance use disorders. Next slide. Our IREACH faculty belong to the various colleges at Washington State University, and we partner with external collaborators at universities across the country. The Institute houses 5 primary research programs, including Partnerships for Native Health. Next slide, please. Partnerships for Native Health conducts community-based research and education to improve health and reduce health disparities among American Indians, Alaska Natives, Native Hawaiians, and Pacific Islanders. We do this by working with both community and academic partners in community settings. We focus on achieving health equity, community outreach and engagement, and training and education. We have over 60 partners across the country, including tribal colleges, Native organizations, tribes and universities, as well as 7 satellite centers located in Alaska, Colorado, Minnesota, New Mexico, North Carolina, Oklahoma, and Washington. Our program focuses on research topics that are important to the populations we serve. Next slide, please. Within the Native Center for Alcohol Research and Education, also known as NCARE, our aim is to optimize alcohol intervention research for public health in general and our Native community partners in particular. We accomplish this goal by collaboratively engaging with research project teams and the pilot projects to conduct research that yields high-quality data while simultaneously meeting the unique needs of our partners. After the conclusion of this webinar, you will be given a chance to provide feedback through an evaluation survey. A recording of this webinar and presentation slides will also be available on our website, ireach.wsu.edu/ncare. At the end of the presentation, there will be time for a Q&A. Please submit your questions using the Q&A box in Zoom. And now I'd like to hand it over to our presenters today. Thank you.
Hi, this is Dr. Amy Elliott. Let me just make sure people can hear me. Gladys,
yes, we can.
Through okay? All right, great, thank you. Well, it is really our honor to present today for NCARE. We've been frequent listeners to other webinars and also have been involved with NCARE with some of the research projects and data safety monitoring boards. And it's just very much our honor to participate in this great dissemination effort. And so we appreciate them asking us to present. So I'm going to present first and then Jyoti will go next. So just a quick intro on myself. My name is Amy Elliott. I am a Chief Clinical Research Officer at Avera Health, which is a large rural health organization based in Sioux Falls, South Dakota, but it covers a good half of South Dakota as well as the western parts of Minnesota, portions of Iowa and Nebraska as well. We also have an extensive telehealth program that actually covers about 22 different states and has around 300 different locations. So rural health is an important aspect of everything we do, and with that, obviously with American Indian health being particularly relevant in our region as well as others, has been an area that we've worked in for the past 20 years. And so we help run all the clinical research, non-oncology clinical research for the health system, and have been very privileged to partner with many communities and actually some individuals I see that are on the call over the past years. So this presentation will really cover the relationship between prenatal alcohol, stillbirth, and SIDS, and is a report out from the Safe Passage study. And so we'll be covering some of the background of this important topic, as well as then kind of the hallmark findings from this study. Next slide. So to overview, we'll go through some general infant mortality information, talk a little bit more about how the Safe Passage study came into being and was designed. And then Jyoti's going to talk a bit more about the regulatory infrastructure that was necessary for this very multi-site, multi-country project, as well as the cultural and ethical considerations, particularly from the American Indian perspective, that really helped inform and improve the protocol as it was in its initial phases of development, as well as then through dissemination, which is where we're at now. And also how we're working to move this from observation to intervention. Next slide. All right, so a little bit more about us. Like I mentioned, we're part of the Avera Health System in South Dakota. We have research offices in Sioux Falls, which is way on the eastern side of the state. So when you're looking at your slide, way on the right side. Rapid City, which is way on the left side in Pennington County, and then also in Pine Ridge. And I know many people are road warriors here that are on the call, and so I don't need to say that, you know, to drive from Sioux Falls to Rapid City typically takes around 6 hours and that Pine Ridge is roughly the size of Connecticut. Anytime we present this to other crowds that don't really understand the vast distances we have between places, they can really underestimate just how large this region really is. Next slide. And so, as many of you know, with translational research, that there are multiple steps in this process. And this slide actually, Dina Roundham originally helped design some of this slide and put some of this concept, I thought, into a really nice visual that also has been seen in other places as well. So we know there's a stepping stone process to this, stairs, if you will. You know, from defining the problem, identifying those causes, developing and testing interventions, and then moving to implementing interventions and measuring prevention effectiveness. We always want to get to those higher level steps and to get off of just continuously defining the problem and even identifying those causes. We want to get to those intervention steps on this. Next slide. So there's numerous concrete tasks that fall under each of these, you know, again, from data collection and surveillance to risk factor identification to evaluation, and then really putting things in the community and demonstrating effectiveness in that public awareness and training programs as well. The challenge with this, though, and next slide, is this can take a really long time. In typical practice, this takes about 17 years to get something really from the beginning step, from a research perspective, all the way through to practice. Next slide. Of course, when we're talking about tribal translational research, we've got, you know, those same steps that are included in these. But next slide. But there's also what can be perceived as somewhat barriers to research participation, both on the the viewpoints of the tribes, as well as from the viewpoints of anyone who may be assisting with any of the scientific aspect of it. Next slide. So as we know, there's oftentimes mistrust for very good reasons, competing demands with just basic needs and other aspects of things that need to be met. Sometimes there's been unintended consequences from research that can have really derailed our research processes for and community harm for many of these. Lack of access to the information, so you just end up a lot of times going in circles a bit, trying to figure out how to access information. And then also is there a stigma for participating in research and what that really means and involves. And I know many of you, as well as NCARE, have worked hard on a lot of these areas in helping turn some of these things around. Next slide. However, with this time frame, what does that do when we're dealing with tribal translational research and its effect on number of years? And so this is something that we, as we're planning, always try to kind of keep in mind, and how can we continuously improve and be more efficient in things that we're doing, more meeting tribal needs, so that we can get to those higher level steps quicker with really good quality work. So next slide. All right, so that takes us to a little bit of what the motivation was to begin with for the Safe Passage study. So what you're looking at here is South Dakota infant mortality rates. The dark or brown line is the United States rates as a total starting in 1990 and going through 2017. And then the lighter brown is the South Dakota total rate. And so as you can see, South Dakota has lower birth numbers, obviously, than the United States as a whole. And so the numbers fluctuate a bit from year to year, and they're relatively low numbers, thank goodness. And as you can see, sometimes we're above the line, sometimes below, more often a little bit above. But if you were just looking at this, you may not think that South Dakota's infant mortality rates are that much different than the country as a whole. Next slide. But where you see a big difference, and this is often the case with many health conditions, is when you look at it by race, what we see is a dramatic difference. So the upper line that's a little bit darker is the American Indian infant mortality rate in just South Dakota. And so as you can see in the early 90s, from like 92 to 95, you can see that the infant mortality rate was about 2.5 times what it was for the rest of the state, and definitely much higher than what we saw in the United States as a total. And it was during this time period that the tribes reached out to the NIH, to the CDC, asking what is going on, how is it that we can save more of our babies? Next slide. One more slide. Thank you. And so I always like to show some good news, though, before I start going into the formation of the Safe Passage study, as well as then some of our findings. We just put a simple trend line with the American Indian data. And what you can see is, and I always tell my students, if you put a marble up on the top of that line, if it rolls down, you've got a descending trend. If it goes backwards, then you've got an upwards trend. And as you can see here, this marble would be rolling really quickly down this line. Over the past 30 years, there has been tremendous efforts on the parts of tribes, community organizations, research, healthcare organizations, state governments, federal governments, you name it, Indian Health Service, to help tackle these infant mortality rates. And all of these efforts as a whole have really been paying off in South Dakota. We are seeing decreasing infant mortality rates. And in fact, if this trend line continues in the direction that it has been going, by the mid-2020s, there would be virtually no health disparity in infant mortality in South Dakota. And how great would that be? But for right now, we still have a difference that we need to make sure doesn't get away from us. The infant mortality rate for American Indians is still twice of what it is for South Dakota as a state as a whole. So, but good news, it's going in the right direction, but there's still a lot of work to do. Next slide. So that period I was telling you about in the early 1900s, 1992 to 1996 in particular, when the tribes reached out to the CDC and the NIH, what ended up forming was called the Aberdeen Area Infant Mortality Study. And this involved investigators from around the country and numerous tribal partners, but it all took place here in the Great Plains area. 9 tribes in 1 urban area participated, and their main purpose was to help determine what the heck is going on with infant mortality in Indian country, and what are the areas that they should look at tackling to decrease this and save more babies. So it really was an exploration to figure out what is going on and what are some possible reasons for this. So it was a retrospective study, and as many of you know, a retrospective study by design is where your outcome of interest has happened, and then you go back and collect information to try to figure out what led up to that outcome. So in this case, the outcome was an infant death, and then after an infant passed away, going back and collecting as much information as possible about the baby's life up until that point to try to help ascertain what was going on, and comparing that with a control group. And so the sample size for this, there were 72 deaths during this time period in the participating communities. About half were confirmed as sudden infant death syndrome. And the definition of sudden infant death syndrome, or SIDS as I'll refer to it, is the death of an infant less than 1 year of age that another cause could not be found, even after an autopsy, a thorough death scene investigation, medical records, and history review. And so it's really a diagnosis of exclusion where all the other things have gotten worked out, ruled out. There have been some changes in this diagnostic category that we've seen over the past couple of decades to have it actually be a little bit more inclusive, and you may hear SUID now being used more, sudden unexpected infant death. At the time PASS was created, SIDS was still what was being used, so I will continue to use SIDS for the purpose of this presentation. But no, it does relate to kind of the larger now definition of SUID as well. And so what they found in this Aberdeen area infant mortality study is three things that they really weren't looking for beforehand, but that rose out as significant risk factors. And these were published in JAMA by IAZU in 2002. And what they found is that if a mom reported drinking during the periconceptional period, and this was the periconceptional period is 3 months before the point of conception, 3 months after. And if a mom reported drinking 1 beer, that made her a yes. They weren't planning on finding this, so the alcohol assessment that was done at that point wasn't very sophisticated, was kind of just more of a yes, no, didn't really get into quantity, frequency, or timing, which we know are critical issues with prenatal alcohol. But if a mom reported drinking during that periconceptional period, it increased the risk of her baby dying from SIDS 6-fold. Now, if a mom reported binge drinking during the first trimester, and at this time binge drinking was defined as 5 drinks on any one occasion, which for those of you, and I know there are many alcohol researchers on this call, but as you know, the standard definitions of drinks tend to be different than how people drink socially. And so 5 drinks actually is a pretty typical drinking pattern in many parts of our country. But if a mom reported binge drinking during that first trimester, and again, often before she knows she's pregnant, it increased the risk of her baby dying 8-fold. Now, these two were the same or higher than what was already a known cause of death, being 2 or more layers of clothing on at the time of death, and that's not including blankets and all of those other things that we know can contribute to overheating. Next slide. So that formed, so with those results from 2002, NIH and as well as in conversation with all of the individuals involved with the Aberdeen area infant mortality study, so this is an area where they're worthy of more exploring. How is it that prenatal alcohol may predispose and make babies vulnerable to SIDS? And so then during that time, there was also speculation that some unexplained stillbirths may actually occur by some of the same biological mechanisms as SIDS. And so what was formed was the Prenatal Alcohol SIDS and Stillbirth Network, so known as PASS, the Safe Passage Network. I'll refer to it as PASS from this point. We had phase 1 time period that went from 2003 to 2006, and that's where we developed hypotheses and protocols and did a lot of pilot and feasibility testing. Phase 2 started in 2006 and ended in 2017. So first thing you may notice, this is a heck of a long time for a study to happen. NIH decided early on that they wanted to work with fewer number of sites and do a more intense study protocol rather than working with a diffuse number of sites and making the protocol a little more streamlined and doing it quicker. They really wanted to be able to answer questions for the 2 primary areas that were involved in this study, which I'll talk about here in a minute. Well, that is South Africa as well as the Great Plains of the United States. And so during this time, we did then the full-scale hypothesis-driven studies that included both prospective and retrospective studies. And we had over 12,000 pregnancies enrolled, 12,192 to be precise. And the Dukes et al. 2014 paper gives a review of the methodology that went into the design of this study. Next slide. So this is what made up the PASS network. So there's the clinical sites. You see the circle up here in the upper left-hand corner. The clinical sites included those that are in the Northern Plains as well as in South Africa. We had a physiology assessment center out of Columbia in New York. We had a data coordinating center in Boston. We had a developmental biology and pathology center that is Harvard Children's Hospital in Boston. And then numerous NIH institutes participated. NICHD, the Child Health and Development, and NIAAA, National Institute for Alcohol Abuse and Alcoholism. They were the initial creators of what became PASS. And then NIDCD, that's the National Institute for Deafness and Communication Disorders, came in a bit later to add some other study-specific elements with it. Now, many of the individuals that were involved from the NIH level, the Physiology Center, and the pathology group all were involved in the Aberdeen Area Infant Mortality Study. And that brought a really nice continuity between what was found and the structure that had been set up for that study to then what became PASS. Next slide. So I always end up showing this slide because people tend to be more familiar with South Africa is, but this also shows where the Dakotas are in the United States. Again, I'm preaching a bit to the choir here, so you guys probably don't need this education, but I've just found that it's amazing how many people don't know where the Dakotas are at. So right in the middle of the country. Next slide. So another piece of evidence that came out of the Aberdeen Area Infant Mortality Study related to the biological mechanism that may be involved with SIDS. And Hannah Kinney and her colleagues came up with a triple risk model for SIDS, which is those three concentric circles that you see, or the Venn diagram that you see on the right-hand side. And what she proposed in this model is that when these three things come together, this is when you get the risk for SIDS. First is a critical time period, which happens to be about 2 to 4 months of age. About 85% of infants die from SIDS between 2 and 4 months of age. And that is a time period when the autonomic nervous system is going through tremendous adjustments and fluctuations, reflexes that were once involuntary are becoming more volitional, as well as a whole host of other things are changing on the neurological level for the infants. The second is there's something about, or that is a stressor, some environmental stressor that tests that baby's system. And this could be things like laying on her stomach, which we know is a risk factor for infant death. Could also be infections, things like that. We often see a lot of times kids that die from SIDS had a cold, gunkiness, some sort of illness, even very mild beforehand. So exactly what this stressor looks like is it can be a little different in all situations, but typically there's some environmental stressor. And then the third circle is a vulnerable infant. And this is where, how does prenatal alcohol play a role in, and smoking ended up being a real significant factor in that as well. How does prenatal alcohol and smoking exposure increase an infant's vulnerability to sudden infant death syndrome? And what Dr. Kinney found, both through, this has now been found in 3 separate cohorts, the first being from the Aberdeen Area Infant Mortality Study, is there's been consistent evidence that in the brainstem, that the neurotransmitter, their serotonergic system, is different in babies that die from SIDS. Next slide. And so if you think about this, I've always liked this slide from Hannah Kinney on kind of what the role of this area of the brainstem is for the infant. And so essentially, if you think of it as the baby's alarm clock, right? When something isn't going right, and either there's a hypoxic type situation, baby's breathing in too much carbon dioxide, asphyxia, hypercarbia, that when one of those situations is happening, it sets off this alarm clock that then increases infants' blood pressure, respiratory rates, and also sends messages up to the motor cortex saying, move, get out of this situation. And what happens when this alarm clock isn't working is that then there's an inability to wake up, essentially, to dangerously low levels of oxygen or dangerously high levels of carbon dioxide during that sleep process. Next slide. And so what this looks like is in step 1, we see a baby here in a compromised sleep environment on their stomach in soft bedding, okay? In a compromised sleep environment, that can form just this little pocket where they're rebreathing air, and can be a dangerous situation. Now, if the baby's little alarm clock is working just fine, what ends up happening is that head lifts or turns, and the baby gets themselves out of that dangerous situation. Even a newborn has the abnormal developmental ability, has the capability of doing this. An infant that is 2 to 4 months old developmentally can almost lift their trunk entirely off of a mattress and extract themselves from that sort of situation. Now, there are times where the environmental situation is such that the infant simply cannot extract them, whether the alarm clock's working or not. It's beyond their physical capabilities. So we're assuming here that normal developmental infant would be able to extract themselves. Now, if that alarm clock isn't working, then we go down to step 2, and you start seeing a failure of arousal that then leads to this progressive asphyxia that then goes to step 3, a hypoxic coma, step 4, bradycardia and gasping, and then step 5, a failure to autoresuscitate resulting in death. Next slide. One of the challenges with problems with this alarm clock is you don't know, and this is where it relates to parents' worst nightmares, you don't know what babies are vulnerable until the postmortem time period after the baby's died, and then it's too late. And so part of also with PASS is to figure out how we can identify this area earlier. So how does this relate to smoking and drinking? Well, Hannah Kinney's group looked at the serotonergic, the arcuate binding in that area of the brainstem, and what she found was that when a mom reported smoking, so the light blue is no smoking, the gray is they smoked during pregnancy, that there was a decrease in binding, and it was significant for smoking and starting to approach significant for drinking. This is a pretty small N that was associated with this, but this combined with some of the epi results suggested this would be an area worthy of further study. Next slide. So again, what we wanted to be able to not just postmortem be able to identify mechanism. We wanted to be able to look at how could we potentially predict or identify which babies may be at greater risk, not just from an epidemiological perspective of risk factors, but from also looking at physiology. And so what you see here is our research associates holding a baby in what we call our tilt bassinet. And they tilt the bassinet up to about 45-degree angle, and we monitor baby's heart rate, blood pressure, as well as other measures of the autonomic nervous system, because those same areas are controlled by that area in the brainstem, to see if we could identify a potential indicator of who might be at risk. Next slide. And so we found this area of the brainstem to be vulnerable and to change during the critical time period of 2 to 4 months. On here, we see a robust change from, this is heart rate variability between newborn and 2 to 4 months. Next slide. Next slide. And also we see a difference if the baby's in the prone sleep position, sleeping on their stomach versus supine. So again, this is starting to match with what we see in epidemiological data. Next slide. Next one. There you go. And also, with how it relates to smoking and drinking, we see a robust heart rate response if there's no smoking and drinking, diminished for smoking, and then diminished for alcohol. Next slide. And so that created a very multidisciplinary approach of looking at these different exposures, also looking at how they relate to the placenta, the central and autonomic nervous system, and relate to different outcomes like stillbirth SIDS and fetal alcohol spectrum disorders. A lot of these analyses are still ongoing. The data set was opened up to the investigators in late 2017. And so I'm going to be reporting on the SIDS, the primary outcome for the Safe Passage study. Next slide. So what PASS created was this common study protocol that really became a very robust study on fetal and infant development. We enrolled women early on in pregnancy, saw them 3 or 4 times in pregnancy, saw them again at the time of delivery, and then at 1 month and at 12 months. and a whole host of things were collected during that time. We often said if it related to fetal and child health, we probably collected it during that time. And with over 12,000 individuals enrolled in this, and many of them leading very, very happy, healthy lives, we have this robust resource for infant and child development. Next slide. And so with alcohol, we often get asked how we collect that. We used a modified timeline follow-back procedure where we gave women calendars, and actually we walked through all of this. A clinical coordinator walked through all of this with them to get at the type, next slide, to get at the type, the size of the container, the number of containers, how many they shared it with, whether it was ice or frozen. We got very, very nuanced data on this. Next slide. And what that allowed us to do is, so with prenatal alcohol data, timing, frequency, and quantity are really your heavy hitters for what you want to look at with alcohol. And what we were able to do is have the participants in 5 different groups, dependent on how much drinking they did at each of the different assessment time points within PASS. So we had a high quit later group, a high continuous group, a moderate quit early group, a low continuous, and a none. So you can see right away how this was a different approach than was used in the Aberdeen Area Infant Mortality Study that was much more of a yes-no. This one we could actually look at timing, frequency, and quantity with these groups. Next slide. In the Northern Plains, just want to highlight, this was an article we recently had come out that just looked at the Northern Plains prenatal alcohol exposure. This is from the PASS cohort. And 2 points I want to make, just highlight on this paper, next slide, is that more Caucasian women drank alcohol during pregnancy. So these dotted lines, the lighter line is Caucasian, the darker line is American Indian. And when you look at the difference between the 2 dotted lines, you can see that more Caucasian women reported drinking during pregnancy, actually at all time points during pregnancy. However, more American Indian women binge drank during pregnancy, which is what the solid lines represent. And again, that was at every time point during pregnancy. So I always like to be able to show this right away, because I think sometimes there's the misperception that drinking during pregnancy is not an issue in Caucasian populations, and that is completely not true, and that actually more Caucasian women drank alcohol during pregnancy in the PASS cohort. However, those American women that did drink were more likely to binge drink. So 2 sides to that coin, but I think can also help inform future efforts. Next slide. So getting back to Safe Passage Study primary outcomes, of the 11,663 pregnancies, there were some who moved out of catchment, withdrew for various reasons. There was 145 women that lost their babies during pregnancy, and there were 77 babies who died after being discharged from the hospital. 28 of those were determined to be SIDS, 11 undetermined even after we looked at everything and we decided we couldn't put them cleanly in any category. And then 38 that had known causes of death, like genetic causes, infection, with respiratory being the largest number of infection, accidental were some of the leading causes there. Next slide. In this cohort, a group of people, we found that there were about 51% that reported no drinking whatsoever, 18.3% that both smoke and drank at some level, and 21.9% that smoked only. And again, you can see the ends for each of these. Because our participants varied so much throughout all of this, we created a propensity score that helped. I like to think of it as a golf score to kind of help even out all the things that we know relate to SIDS. And so created a propensity score that was applied to this that took into account recruitment location, maternal age, race, marital status, education, diabetes, parity, and then also a proxy for body mass index. Next slide. So this is the, next slide, I think. Put the red circle around it. Thank you. This is really the part of the slide I want you to look at. This is right from the paper that was published in the Lancet eClinical Medicine earlier this year. And what this shows is this is comparing infants that died from SIDS for those that were alive at 1 year. If they reported drinking only, the relative risk increased for the SIDS infants about 3.95. So if a mom drank only during pregnancy, and I should mention this is drinking and smoking after the first trimester, it increased the risk of her baby dying from SIDS a little under 3.95. If a mom smoked only, and this again after the first trimester, the risk of her baby dying from SIDS increased by 4.86. However, if a mom smoked and drank past the first trimester, we see this risk jump up to an astounding 11.79, which is just a crazy amount. We also can look at those with known causes of death, which is the last 3 columns here, and there were no significant associations for any of the different levels of exposure if it was a known cause of death. We only saw these significant exposures or significant increases in risk for the SIDS infants. Next slide. So that is the primary finding from the PASS network, and so I'm going to turn it to Jyoti to talk a little bit about the regulatory infrastructure that supported this work.
Thank you, Amy. Can you hear me?
Yep.
Okay. So thank you for giving us an opportunity to present on the study again. My name is Jyoti Angal, and I'm the Director for Clinical Research and have been part of the PASS study since it started. And so I'm going to talk a little bit about the regulatory setup for this study and all of the parts that contributed to the success of the community-based effort. Next slide. So since one of the complicated parts about putting in a study that's collecting sensitive information is protecting participant privacy and confidentiality. So we had to obtain a certificate of confidentiality, and this is something that NIH now awards to all grantees that are collecting sensitive information, but at that time it was only selectively given out to certain projects. And so what the certificate essentially does is protects participants by preventing forced disclosures from investigators, and I'll talk about it just in a minute or so. Another thing we had to put in place was a memorandum of understanding with the state of South Dakota, basically saying that they would honor the certificate of confidentiality. And this was done because the state of South Dakota is one of the really few states where prenatal alcohol is considered to be child abuse. And so in order to protect our moms that were participating in the study, we had to put something in place so that the state would not attempt to prosecute the investigators or the participants for being part of the study. And then the final component of the regulatory infrastructure was the multiple IRBs that were part of the study. This was before the single IRB time, and so there were as many institutions as there were IRBs. And then we also had, with the tribes involved, we worked with many of the tribal IRBs as well. Next slide. So just a quick word about the certificate of confidentiality. So this is an authorization that gives investigators protection from being compelled to reveal identity or identifiers. So initially, the certificate of confidentiality protected identity. It's now moving to where it will also protect some of the data. And then the certificate authorizes an investigator to protect the identity of the study subjects. So what essentially it says is if you do not voluntarily disclose the identity, then this certificate will protect the participant. Next slide. So one of the goals of community-based research, and again, like Amy said, many of you are familiar with this, is that a successful collaboration with research occurs when the research finds a good way to fit within the culture. And so for this study, at the very beginning, we had several meetings with elders, with community leaders, with medicine men to make sure that we were setting up the study in the right way. You have a successful collaboration when researchers are willing to have those difficult conversations. And then by saying how research fits into culture, the researcher understands why some individuals may choose to participate and others do not. Next slide. So in the safe facet study, the tribal IRBs played a very significant role. We had the privilege of working with them from the beginning to get input on research design and implementation. They provided input on selection of recruitment sites, reviewed the study protocols and the questionnaires. Because the study was about infant mortality and specimen collection, there were extensive discussions about how we were going to collect genetics data, placenta, what are the cultural perspectives on infant death, and how do you approach a family when you are asking for information after the demise of an infant, and what are childcare practices that we should be thinking of. A hallmark of those conversations was how consents and processes were revised to meet cultural perspectives. So for example, the Safe Facet study asked for permission of participants to share specimens for future research. So in working with one of the tribes, they wanted a somewhat restrictive permissions for future use of specimens, in that they only wanted specimens shared with the past study researchers because a trust-based relationship was built with the researchers, but did not want broad sharing of specimens. And so we were able to accommodate that request and allow for that, giving an opportunity to everybody that wanted to participate to be able to do that. They've also provided information on genetic studies and wanted to make sure that participants were provided additional information on what it meant to donate specimens for genetic studies. A lot of discussion happened about how post-mortem specimens were collected. For this study, we had to collect specimens within 48 hours of demise. And as you can imagine, that period is probably the worst period in a family's life. And to be able to approach a family sensitively, be responsive to whatever the cultural protocols that might happen during that time was really important to the success of the study. Next slide. So based on one of our experiences with these participants, we published this paper on just our work with both in South Africa and in the Northern Plains on the approach to collecting information post-autopsy. Next slide. So with that kind of was the wrap up of the Safe Facet study. But as Amy said, kind of the next step was to how do you take the next step from moving on from defining the problem to doing something about it. So while working with Safe Passage, it was pretty clear that unsafe sleep environment was one of the major causes for infant demises. And so that was something we really wanted to see if we could put something in place that would help with that problem. Next slide. So an opportunity came by when NIH put forth a request for application asking for interventions that could be put in place, culturally based interventions to promote safe sleep practices. And we were able to work with one of the tribes involved in the Safe Facet study to come together and bring up a curriculum that would incorporate cultural practices into the practices that are promoted by American Academy of Pediatrics. And we developed a curriculum that's called Protecting Babies While They Sleep. This study, next slide. So what we tried to do is, in talking to the elders when this study was coming together, is how could we incorporate wisdom of traditional practices with what we know, what science says. So for example, in talking to elders, the themes that came out were that babies should never be left alone, and that kind of meets the AAP recommendation of room sharing. They also said babies should, in the olden days, slept on firm surfaces on their backs, often in cradle boards. That again meets with the recommendation that babies should be sleeping on a separate hard surface, not a soft surface. And then they talked about how babies were exclusively breastfed, which is also a recommendation for reducing the risk of SIDS. So as we were working on this study, we were able to see how much these two recommendations mesh and how important it is to incorporate cultural wisdom and practices in designing curriculums. Next slide. So this trial that we are doing is still underway. It's funded through NICHD, and it's looking at a two-group randomized trial with a sample of about 150 pregnant Native American women. 75 will be reservation-based, 75 are in Rapid City. And we have wrapped up enrollment right now and are in the follow-up phase, and so hoping to present more on the study in future. Next slide. So I'm going to wrap up with just a couple of slides about the lessons learned from our work in Safe Passage study and then with this Safe Sleep study. Next slide. So as we can appreciate, community partnerships are essential. CBPR methods help with open communication. Dissemination and communication at all phases of research is critical. We've attempted to do that through Safe Passage, not only during the end of the study, as we are doing now, but all throughout the study process. Respect and support for tribal research processes are key, and the timeline for moving from research, from finding the problem may sometimes be longer than expected. Next slide. So we had seen the slide before, and at that time we were wondering what it would be in tribal translational research. So this is from how much time we've taken for when the Safe Passage study happened to when this intervention study was put up. So it's actually less than what we would expect in other circumstances. Next slide. All right. With that, we'll wrap up our presentation today. These are the acknowledgements for the sponsors and funders that have we worked with over the years, and also we want to acknowledge all of the contributions of our participants and staff, community advisory boards, and leaders that have worked on the study. So with that, we will open up for questions.
Thank you so much. What a wonderful presentation and such important work. I love that you, in the end, were able to share, you know, from inception to intervention, the process taking 13 years, and such a great deal of learning has taken place over that time. So we're going to open up the question and answer period. Please do type your questions into the Q&A box, and I'll read them out loud, and we'll get our presenters to respond. Okay, we have a question from Jessica. Great presentation. I was wondering if you could talk about your hypothesis on why the combination of alcohol and smoking can be so harmful, and why we aren't focused more on the harms of smoking.
Take myself off mute. You'd think I'd know that better by now. No, that is a really good question. And we've got a few hypotheses why we think this may be. For example, both smoking and alcohol bind to some of the same areas on the placenta. And so we think that that could be where this synergetic additive effect happens with that. And so that's one of the things that we're actually in analyses now, looking at different binding levels, both within the area of a brainstem as well as on the placenta. There's also just, you know, the general stress that may happen, and even if they're not operating on the same parts of the body, that could also serve as somewhat of the synergistic effect. So biologically, we're not sure yet. We've got some hypotheses around that. I do think that it would also be interesting to look at socially for those with multiple exposures, if there was additional adverse social exposures that were going on, such as maternal depression, anxiety, difficult home lives, those sorts of things, also would be an interesting analysis that we would be able to look at. I haven't done that yet, but those would be things I would speculate and think would be some good next steps to look at it. In terms of why aren't we focused more on the harms of smoking, we definitely should be focusing more on the harms of smoking. And I do think that, I know in our work, we've greatly expanded to not just include prenatal alcohol, but also smoking and other drugs in addition to that. As marijuana becomes increasingly common across the United States as well, there's a lot not known about that and the effects of that during pregnancy as well. So we're finding polysubstance use is including alcohol and nicotine is the norm rather than the exception. And by looking just in one area, we might be missing much of the larger picture. So definitely like the expanded focus.
Great, thank you for that. I have another question for you from Marie. Was the work that was done in South Africa primarily with Indigenous peoples, or was it with different types of populations?
Jyoti, you want to take that one?
Yeah, sure. So, so that's a great question too. So in the population that we worked with in South Africa was called the Cape Colored population, and this population was of mixed race ancestry. So they it was mixed Black, Caucasian, Asian, and so so the history with this population was during the apartheid rule, this population was employed in vineyards, and they were paid in wine. So the more they work, the more wine they get paid. They got paid at that time, and so in that region and in the population, they had a legacy of kind of drinking, and then the high rates of fetal alcohol syndrome subsequently. So, and the high rates of SIDS. So the two populations, really, the Northern Plains populations and those in South Africa had comparable risks for SIDS, which was kind of the motivation for including them.
Thank you for that. And it looks like I have someone with their hand raised. Sarah, I'm going to unmute you if you wanted to share your question. Oh, you have to unmute yourself. Apologies. Okay. Are there any other? Oh, here we go. We're intimate partner. I have a question in the chat box again here. We're intimate partner violence and the stable relationship with the same male partner assessed and published from this study? If not, could a research question be analyzed by the core study investigators, but proposed by outside researchers? Was some type of the relationship education from the tribal seniors to young parents assessed as a protective factor in the study?
I know questions.
Yeah, no, great question. You know, they were assessed somewhat, but they weren't the primary focus of PASS. So I can't say that the best measures and things were used in those assessments of partner violence and stable relationship. We did look, you know, have a pretty extensive assessment with depression, anxiety, and perceived stress, which gets at some of those different aspects. We had incorporated a few more things on partner violence as well as post-traumatic stress disorder and things like that during a subset of PASS, but didn't include that throughout the entire study, partially because it was becoming a little unwieldy, and so we kind of had to only pick things really central to that primary hypothesis. I wish we kind of had included more of those longer term, but there might be some things that can be pulled out from our data part with that, and would encourage if someone was interested in exploring that further to contact me, and that might be something we could look at working on together. So we've got some mechanisms to be able to help with some of that data analysis and see. So if someone's interested in that, please contact me and can see if we can dig through the data set. If I can give you, anyway, if we can identify some variables and things like that that might be possible, and then we could work with them in helping answer that kind of very important question. In terms of the education from the tribal seniors to young parents, we did not assess that. That's something actually we included a lot in the intervention study and kind of corrected that as we went forward.
Great. I have one more question here from Marie. How are the findings, for example, native wisdom and research findings, translating into interventions, and is that currently being implemented?
So I think this question relates to the infant care practices study. And so that's, again, a good question. So as part of there's two parts of the study. The first part was developing the curriculum that would incorporate these teachings and guidances from the Native elders into developing the curriculum. And then the second part was testing the intervention. So we are still in the phase of testing the intervention and then hoping to, once that is done, to be able to broadly disseminate it. So to answer the question, it is not being implemented clinically, it's still being tested.
Great. Well, we are about at time. I want to thank you both very much for sharing the insights from your project with us today and spending some time answering the questions. The contact information for Amy and Jyoti is on the screen there. And to let everyone know that we will be sending out a link to this recording in a couple of days once it's uploaded to our website. Please do complete the survey that's going to pop up on your screen once the Zoom webinar ends. We would love your feedback and look forward to you joining us at another presentation. Take care, everyone. Have a great day.
Thank you.